Okay. Okay, guys, thank you for attending. So this is an interesting case that I just encountered for the past couple of weeks, okay? Okay, so the history goes is this is a 15 years old female, okay? She was largely asymptomatic except for non-specific symptoms, mainly fatigue on exertion, a little bit of chest tightness and muscle pain, okay? However, in May 2022, she did have an episode of dizziness in the setting of dehydration while walking at the beach. Okay, so this has prompted first evaluation of the patient, and an ECG was obtained. Okay, so really quick, guys, can someone quickly interpret that ECG? Anyone? It's not tricky, It's classical for what?
Sinus.
Yeah, sinus rhythm.
Left ventricular hypertrophy.
Yeah, so there is definitely increased voltage.
Left ventricle.
Yeah, on the left side, plus strain pattern, right?
Strain pattern, inverted Q wave, yes.
Yeah, okay. Okay, so no WW, a little bit of definitely LVH with strain pattern, okay? Maybe Q waves in AVL as well, okay? Okay, so very concerning ECG, very abnormal ECG. I don't have the cardiac, examination of the patient, but an echo was done, which showed hypertrophic cardiomyopathy that was non-obstructive. Okay, MRI was performed quickly thereafter, showing localized hypertrophy in the posterior-basal region, maximum thickening of 2.6 centimeters or 26 millimeters. However, with normal LV and RV ejection fraction, there was no RV thickening, and there was less than 5% of the late gadolinium enhancement. Okay, so there is a scar, but not huge. She had a Holter as well with very few PVCs, like roughly 4. And because of her symptoms, she was recommended to be on bisoprolol. Okay. Okay. So again, immediately thereafter, genetic testing was done, which showed pathogenic mutation in LAMP2. Okay. Which has been previously reported, by the way, in at least 4 individuals. And this mutation is known to cause Danon disease, which I'll explain later. And because it results in termination codon, or it causes a premature termination codon, so the protein that is formed is usually absent or very, very truncated, resulting in loss of function of the LAMP2 protein, okay? And this causes Danon disease, okay? So these parents were negative, by the way. So this was a de novo mutation, and this is the first known case in Kuwait of Danon disease, okay? So I'm not very sure whether anyone had seen Danon disease in the past. Anyone had seen Danon disease, guys, in the past? Maybe in Egypt or somewhere else? No?
No.
Did you see it in UK?
No. No.
Okay, it's a very rare disease. Okay, so let's talk about it. Okay. So Danon disease is a rare X-linked dominant metabolic disorder. Okay, so because it's X-linked, it is definitely more aggressive in men. Okay, and men with Danon disease transmit the mutation to their daughters, but not their sons, obviously. It was initially described by Danon and others, and such patients usually have cardiomyopathy, mainly hypertrophic cardiomyopathy. Maybe at later stages, dilated cardiomyopathy might be present. in addition to skeletal myopathy and cognitive disorder. Okay, this was first described in 1981. Okay, later reports had shown that such patients also have retinal disease, hematological disease, hepatic disease, and pulmonary disease. Okay, this is it's an autopsy specimen of one patient with Danon, and you can see the severe LV hypertrophy of this patient, probably resulting in his death. Okay, so yes, it's a multi-system disease, but heart failure and arrhythmia are the main symptoms and the leading cause of morbidity and mortality for such patients. Okay. So it is caused by deficiency in lysosome associated membrane protein 2. Okay, so leading to failure of final step of autophagic process, in which digestion of aged cellular components, including glycogen and other organelles, is taking place. So the cell is unable to get rid of the aged cellular contents, and this leads to massive accumulation of such contents in vesicles called autophagosomes, so the aged cellular components are typically formed into vesicles, and then this is is usually the cell is able to get rid of it usually, but with this disease the cell is unable to get rid of the aged cellular components. Okay, and specifically the inability to remove aged mitochondria, for example, would lead to mitochondrial dysfunction, energetic deficiency, and oxidative stress. Okay, so this is an example of cardiac and skeletal muscle of other patient with Danon syndrome, in which you see these autophagosomes or vesicles, okay, everywhere. Okay, so this is a pathological marker for the disease. Okay, again, accumulation of immature vacuoles or autophagic vacuoles or autophagosomes, predominantly found in cardiac and skeletal muscles. Okay, causing disease in the cardiac muscle and disease in the skeletal muscle. Okay, so one of the largest and most recent papers for Danon disease was recently published in 2020. This is a European cohort. They included patients with Danon disease in Europe, and they were able to it's a multi-center study. They were able to identify 57 patients with pathogenic LAMP2 mutations. Okay, so as expected, men would manifest the disease sooner. So for example, mostly at around 15 years of age, versus in women where they usually present later in life. Men are usually, men in blue, by the way, men usually are more symptomatic and are they are symptomatic sooner than females, and they require heart transplantation sooner than females as well, and they die from the disease usually sooner than females. Okay, as expected. Okay, but it's a very malignant disease, and in this cohort, around 25% of patients underwent heart transplantation, and another 25% died from the disease. So it's a very, very malignant disease. Okay, in terms of extracardiac manifestations, they are multiple, but usually mild, and again, way more frequent in males. Okay, so definitely mild, but very much more frequent in men. Okay, and luckily they are mainly mild, and specifically neurobehavioral issues are usually mild to moderate at most, and very, very mild in females. Okay, so this is the detailed characteristics of the 57 patients. Again, most have, so around 73% of men and 73% or 74% of women did have left ventricular hypertrophy. Okay, otherwise dilated cardiomyopathy in the remaining 25%. And many of them had arrhythmia, issues. For example, WW was highly present in the cohort, heart block, AFib, sustained VT, VF, and many required also ICDs or pacemakers as well. Okay. Questions, guys? Am I too quick or is it good? Straightforward?
No.
Yeah?
Yes, it's okay.
Okay. These are the patients who died from the in the cohort, like we said, around 25%. And some died suddenly, but many died as a result of heart failure symptoms. Okay. And as you can see, most are dying at a younger age. Okay, young age. And many did have some form of arrhythmia. Okay. Heart function was preserved in some and decreased in others, and many had already devices but they still died. Okay. Some had transplanted, some were already transplanted as well. Okay. So again, in terms of wall thickening, by the way, most had some ventricular hypertrophy, but not massive. Okay. Again, only very few are above 30 or 30 millimeters. But almost all had a little bit of ventricular hypertrophy, almost all had arrhythmias, and almost all had devices, but the heart failure was the leading cause of death. Okay. And then when they did analysis in terms of risk factors for death with multivariable analysis, only hypokinetic LV was a risk factor for sudden death. With univariate analysis, atrial fibrillation and heart block, like advanced heart block, were also risk factors, but only with univariate analysis. Okay. So this is the Kaplan-Meier curve, just showing that. So these are the blue and orange in this graph is men. So this is just showing that most men, show the disease prior to, and during their early, during their, young age groups, at young age groups. Okay, for example, like 30% already, had symptoms just before 10 years of age. Okay, and again, so here the blue and the green are men. So many died, before 30 years of age. Okay, so there's a very steep decline in survival, especially in men, from the second decade onwards. So when they reach 20, they are really at high risk of death, especially men. Okay. And like we said, our mutation, this patient mutation, was already reported in the past, and in this cohort, among the 57 patients in this cohort or registry, so this is the exact same mutation that our patient had. So 3 patients had the exact same mutation. Okay. So again, it was previously published. Okay. So Danon disease, again, is associated with severe cardiac morbidity, as you can see, and mortality in both men and women. There is high expression and penetrance rate, and there's rapid progression of disease, like we had seen in the Kaplan-Meier curves. Okay. There were pronounced differences among both genders in extracardiac manifestations, for example, neurological symptoms, skeletal muscle symptoms, but not in the cardiac symptoms. It's pretty much both are affected severely. Okay. And the majority developed heart failure close to the time of diagnosis. So again, rapid progression of disease. Okay. And this, as expected, often leads to heart transplantation, or if this is not possible, to death. Okay. So, why do women, are less affected? Because again, they do have two X's, and it's an X-linked disease, and they usually as a result they usually experience milder and variable symptoms, especially due to X chromosome inactivation, variable patterns of X chromosome inactivation. Okay. And in this cohort, in this European registry, there were like around 22% of them had de novo mutations, meaning no family history and both parents are negative. So it's a new mutation for this individual. And this shows that it's a severe early onset disease affecting the ability to reproduce. Okay, so that's why many of them, or like around 25% of them, had no family history, and they were the only patients that are sick with this disease. Okay. We don't know exactly how common how common is Danon disease, but it's definitely rare, in some cohorts, but in referral centers only, it might be as common as 4% of all patients with HCM. But this is probably not, this is only for referral centers, but non-referral centers probably even less so. Okay. When you have HCM with WBW, maybe the chances of Danon disease is higher. Or obviously, if you have a patient with HCM and there is a skeletal myopathy and someone did a biopsy and did see the vesicles that we had seen or the autovacuosomes, then obviously Danon disease incidence in this individual would be higher, around maybe 33%. Okay. Okay. So like we had seen, many patients had heart block, so it affects the conduction system as well. And it was noted that also it might present postpartum, so pregnancy might affect, women with this disease. Okay. So this is just so you know, this is a list of possible syndromes or diseases with WW and cardiomyopathy. And obviously, like we said, Danon disease is one of them. Okay. But there are a list of differential diagnoses. Okay. So whenever you see HCM with WW, you have to think of these diseases. Okay. Okay. So in conclusion, Danon disease, like we said, is expressed earlier in men, but it's very malignant in both genders. Okay. And mostly would result in heart failure soon and complications thereafter from heart failure. And arrhythmia is also very common among both genders. Okay. The diagnosis and management is extremely challenging in women because they don't manifest the extracardiac manifestations. So genetic testing is very important. This is why we always recommend genetic testing when you see HCM, because sometimes you cannot clinically diagnose Danon disease without genetic testing, for example. Okay. Early diagnosis is very important because, like we know, it's aggressive disease, it's rapidly progressive disease, and you need to interfere early. Okay. And obviously to counsel the family and so forth. Okay. Obviously, there is no specific treatment for Danon disease as of yet, but there is gene therapy trials ongoing for Danon disease. So hopefully there is a specific treatment for Danon disease in the near future. And I am aware of trials that are happening at UCSD and New Zealand. So there is a couple of trials for Danon disease specifically, usually focusing on men because they are the most diseased. But for now, as much as we can is treating heart failure symptoms and addressing the conduction disease as much as we can, and transplanting patients when needed. Okay. Okay. So for this, back to this patient. Any questions, guys, so far?
What kinds of arrhythmias?
Well, like we said in the table, remember, heart block, AFib, VT. Okay. And if there's WW, obviously SVT. Okay. So, almost everything. Okay.
دكتور محمد معلش
Yeah.
البروجريشن بتاعه سريع ولا
Very,
بطيء؟
very rapid. I don't know whether you had seen the, did you see the graph here? If you see the Kaplan-Meier curve here. So this
Oh.
is, this is 0 years of age. And by 30 years of age in men, most of, many of them, 80% of men already had manifestations of the disease. Okay. So 80% of men before age 30 already have the disease, and are already, this is already died from the disease. Okay.
Mm.
Okay. So it's very, very common. Sorry, very severe. Okay. 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 So for back to this patient, so now we have this 16 or 15 years old female with Danon disease and thickening of the LV at around 26 millimeter. She had a little bit of dizziness, but no syncope, and no like VT that we know of, except for rare PBCs. Okay, so this is her story. She had already seen 2 experts in Danon, like abroad, and she was recommended to restrict from exercise, like like severe exercise, meaning you avoid strenuous exhaustion and strenuous physical activity, because there are studies for Danon mice. When the mice is exercising, there was rapid progression of LV hypertrophy and dilation and decreased EF. Okay, so strenuous physical activity it should be avoided, and also starvation. Again, Danon mice that are treated with calorie restriction demonstrated or showed impaired EF and increased fibrosis. Okay, so this is a study from 2022, just recent. Okay, so starvation and exercise restriction should be avoided. Okay, so this is what is recommended for this patient. Again, why is this? Because activation of cell death should be avoided, because the patient is unable to get rid of these cells, organelles that are dying. Okay, but like we know, obviously, if you're not exercising and you're eating so much, you will get obese, and then there is issues with obesity, right? So you have to balance, of course, but as much as you can. Okay. In addition, because of the heart block and SVT and VT and AFib, probably high probability, you should monitor the patient, closely. Obviously, loop implantation is very high yield for this patient, because you don't want to miss the arrhythmia or the heart block that she might be having. And so this is a subcutaneous loop that is implanted under the skin, and usually with a battery life of like 2 to 3 years. Okay. I did recommend the family to undergo BLS training, purchase an AED if ICD was not implanted, just in case something happens to the patient. Obviously, we have to evaluate or refer to heart transplantation team or heart failure team whenever we see decline in EF. Okay. Like you guys know, we had talked about this in the past. We have to balance in pediatrics, at least we have to balance between the sudden cardiac death risk and ICD implantation and complication from ICD in the young. Okay, so there is definitely high ICD complications in pediatrics compared to adults. So you have to balance, the cardiac death risk versus the complications from ICD implantation. Okay, but for HCMs in general, ICD is the only method to prevent sudden cardiac death. Beta blockers have never been shown to prevent sudden cardiac death in HCMs. Okay, so if you're worried about sudden cardiac death, ICD is your only mean to to treat sudden cardiac, death potential. Okay, so as a result, obviously you want to implant the ICD, whenever you think it's indicated. Okay. And like we talked before, there is transvenous form of ICD and subcutaneous form of ICD, and in infants or in the very young, there's epicardial forms. And we said before, subcutaneous form is good because there is no risk of DVT, there's no risk of endocarditis, there's no risk of TR across the tricuspid valve, but the transvenous form is good because it paces the heart if need be. Okay, and if the patient heart block, the transvenous form is able to pace the heart painlessly. Okay, subcutaneous form is very, you cannot, you can pace the heart, but it's very painful. Okay, so you have to discuss all the forms of ICD, or you have to think about the ICD first, and then if you decide for ICD, you have to think what type of ICD you should implant. Okay, so in general, if this patient, God forbid, had sustained VT or arrested, then no-brainer, definite ICD requirement for her. But in her case so far, we have to study how much risks does she have, and then we have to figure out whether she needs an ICD now or not. Okay, so the big question is for her, does she need ICD now? Yes or no? Okay, so in order to answer this question, obviously you have to be aware of the data. Okay, so according to the AHA guidelines for HCM, okay, in adults, okay, usually what adults do is they look they take into consideration these factors, family history of sudden cardiac death, massive LVH, meaning more than 3 centimeters in any segment of the LV, unexplained syncope, if there is systolic dysfunction, if there is apical aneurysm, if there is extensive late gadolinium enhancement, and it's defined as more than 15%, and if there is non-sustained VT on monitor. Okay, so this is adult data. Okay, and pediatric specific, in case you're wondering what is massive LVH for pediatrics, it's defined as Z-score of more than 20. Okay, or more than 10 in conjunction with other risk factors. Okay, in terms of LGE, there's no definition of LGE threshold for LGE in pediatrics, so we don't know what percent is high risk for pediatrics. Any percent is high risk, but we don't know what is the threshold for like a very high risk in pediatrics. Okay, in adults, apparently the threshold is, or the number is 15%. Okay, and obviously, for VT to be counted, for a VT, non-sustained VT, it has to be 20% faster than your basic or basal sinus rate, okay, to call it VT. Okay, questions here, guys? So obviously she doesn't have family history of sudden death. She she's almost an adult. She's 15 years old. So if you think of her as an adult, she's not massive LVH, but she's almost massive LVH. Okay, otherwise she doesn't have unexplained syncope, she doesn't have decreased function, no apical aneurysm. She has a little bit of LGE, but not 15%, and she doesn't have VT. Okay, so she definitely she doesn't have any risk factor, but she's approaching the massive LVH risk factor. Okay, guys? Okay, so knowing this, so this guideline would suggest, again, ICD implantation if there is arrest or VT, sustained VT, which she doesn't have, as class 1. Okay, and for pediatrics, class 2A indication would be if she had one or more the risk factor that we just mentioned. Okay, so again, she doesn't have any yet, but she's approaching at least one risk factor. Okay, and again, remember, you don't want to implant ICD prematurely because we are already doing this. So this is a paper from 2019 in including pediatric patients with HCM and ICDs. And for primary prevention indications, meaning someone who had an ICD, not because he arrested or had sustained VD, just because he had some other risk factor. This is the blue line here, primary prevention. So by 10 years after implantation, only maybe 30% or 40% of them required the ICD. Okay. So many of them never required ICD. Okay. So in the median time to intervention was around 3 years. Okay. So we are as if we are implanting ICDs at least 3 years prematurely. Okay. Okay. So we're definitely implanting ICDs a little bit prematurely. And you have to balance, obviously, we as we said, we don't want to implant ICD prematurely because of the complications rates in pediatrics, but obviously we don't want to lose patients as well and miss patient, with high risks and not implanting ICD, and then he developed cardiac arrest and never survives it. Okay, so we have to be careful. Okay, so by 5 years, only 20% in primary prevention needed their ICD. So again, not very much. Okay, questions, guys, here? Easy so far? Yeah.
محمد طيب في أي medications يعني ممكن تتاخد لو ما فيش مثلا فرصة للهارت transplantation أو عقبال ما تعمل heart transplantation؟
Yeah, well, like we said, there's no specific treatment yet. If you think she needs an ICD, you give her ICD. If you think she needs pacemaker, you give her a pacemaker. And then you treat, you might, any symptomatic HCM. I'll talk about the symptomatic HCM, but you can give beta blockers and ACE inhibitors and, heart failure management. And then, transplantation evaluation when she's approaching the need for transplant, but there's no specific treatment yet, but there will be specific treatment for Danon, hopefully in the next couple, 10 years or so. Okay. Because like we said, there is already trials undergoing. Okay. Okay. So very recently again in 2019, there has been development of risk prediction models for sudden cardiac death in HCM in pediatrics, specifically for pediatrics. There are for adults, but this is only in 2019 onwards, there have been risk calculators for pediatrics. Okay, so this is one of them, and you can use this risk calculator for your patients, and accordingly you can decide whether this patient needs an ICD or not. And you have to input the gender, weight, body surface area, and LA diameter, and so forth. Okay, alveolar gradient, muscle thickness, and so forth. And accordingly, it will calculate the risk for you over the next 5 years. Okay, so if a patient of yours had more than 6% risk, then for every 10 ICD implants, you will definitely save one patient. Okay, so the higher the risk, obviously, the more the ICD is required, and but if you are below 6% risk per this calculator, then you can wait for an ICD to be implanted, but above 6%, then you might want to implant an ICD. Okay, and there's another risk calculator that is a little bit more recent in 2020, using roughly the exact same parameters. Again, age, height, weight, maximal thickening anywhere in the LV. LA diameter is important. Okay, whether there is any VT, whether it's genetic, genotype positive, and so forth, and then it will give you a risk over the next 5 years as well. Okay, I did not do risk calculators for this patient because I don't have LA diameter, but roughly she will probably be around 6% and more, I would imagine, okay, because of the LV thickening that she does have. I just guessed her LA diameter, for example, and this is her risk. So for over the 5 years, you know, she's definitely at around 18-20% risk for sudden cardiac death in the next 5 years, okay? But again, I don't have her exact numbers, so I cannot tell for sure. But, you know, because her echo was done elsewhere, but we will repeat the echo at Chest Hospital, and then we'll do the exact, you know, measurements, and then we will tell Dad what is her risk, okay, for sudden cardiac death. And accordingly, we'll decide, okay? So, Marwa, to answer your question, you know, if you have non-obstructive HCM and symptoms, people usually start beta blockers, okay? And you might add ACE inhibitor as well, okay? And this is why she was recommended to start beta blockers, because she was having symptoms, okay? Again, for
طب دكتور انا جالي عيان مره في
Yeah.
العياده بيشنت dilated cardiomyopathy وماشي على الفالسرتان والكارفيدولول. احنا امتى بندي فالسرتان في الدايليتد cardiomyopathy؟
Well, I mean, she did not tolerate ACE inhibitor or what?
لا هو كان suspected ان هو viral.
Viral?
كان suspected ان هو viral بس هو ماشي على الفالسرتان.
Yeah, and I don't know who started valsartan, but they did not, she's not on beta blockers?
نو هو فالسرتان وكارفيدولول بس.
متأكدة ان هي
She's not carved, huh?
هو كان
هايبرتروفيك ولا دايليت؟
dilated
لا
cardiomyopathy.
لا بتكلم على الهايبرتروفيك.
We're talking about HCM, okay?
من
Okay, it's different, obviously, two different diseases, okay? Okay.
فالزرتان ده اكيد not in our center, maybe in US.
Maybe.
Even if dilated valsartan, we don't write valsartan.
Okay.
Okay. And for sports and activity,
بس معلش يا محمد، هو يعني في new information هنا اللي هو البيتا بلوكر.
yeah.
He said even in non-obstructive.
Yeah. In
But if the symptoms of angina.
Or dyspnea. I mean, you know, she does
angina or
complain.
dyspnea. So
Yeah,
we can start the beta.
Yeah, she does complain of a little bit of dyspnea on exertion. So this is probably why the experts recommended beta blockers. You know, very, very non-specific symptoms, to be honest, but she was recommended by an expert in Danon to start beta blocker, okay? Not by me, by an, like, you know, definitely very, I mean, very well-known individual, okay? But this is the guidelines, you know? So if you have, you know, exertional angina or dyspnea, you should start beta blocker, okay? Or, of course, calcium.
Beta blockers started outside or?
It is, well, yeah, I mean, he tried, yeah, so
outside. Okay.
outside, well, I think she was given in Kuwait based on the recommendation from the outside expert, okay? Same thing, roughly, okay? So for sports and activity, just so you know, again, mild to moderate recreational exercise is okay, but again, strenuous, like we said, activity is not good for Danon. I mean, these guidelines are for HCM in general, not specifically for Danon, but for Danon, definitely strenuous exercise should be avoided. But in general, for HCM, mild to moderate recreational exercise is okay. But of course, when you have an athlete, it's a different story, okay? You have to discuss, you know, risks and benefits with the patient himself and go from there, okay? Okay, so what are we, so like we said, she had all her investigations in roughly May, so it has been a little while. So we are now, so I just met Dad for the first time last week, and we are in the process of repeating the MRI, because you know, she's scheduled for repeat MRI in March, so roughly almost a year from the initial MRI. Again, I'm worried about the maximum LVH diameter, and if indeed she's around 30 millimeters, then she definitely will meet ICD indication, okay? I want to risk assess her based on the calculator that the newly published risk calculators for pediatrics. I mean, because she's 15, so she's almost, she's between pediatrics and adults, but the adult calculators are specifically mention that you should not use them for less than 16 years old patients, okay? And, if we guess, if we said no ICD for now, then probably loop implant is definitely important. And by the way, the experts that saw her, there are 2 experts, like we said, they said no need for ICD yet, but very close monitoring, okay? Obviously, because of the, like we said, there's extracardiac manifestations. She doesn't have skeletal muscle disease. I mean, she does have skeletal muscle fatigue that everyone does. So I'm not very worried about the skeletal muscle manifestations that she's complaining of. But ophthalmology, I'm not an expert in ophthalmology, of course, and I think she requires ophthalmology consultation because, like we said, it affects the the retina of the eye as well. And neurologically, she seems very intact. And in women, it's very mild, if anything, the neurological symptoms. Okay. Okay, so I think I have just one question. Let's just see. So, okay, so we are done. It's a nice, rare, short, but very interesting case. I thought I should share with you guys. So let me just read the question here. Would you calculate the risk in Yes.
دكتور محمد معلش، لما انا ببقى دايجنوز حاله فور فيرست تايم hypertrophic cardiomyopathy كويس وابعتها فور ميتابوليك سكرينينج، هل بيعملوا له
Genetic
بقى
or metabolic, you mean? Yeah, and you talk about an infant, you talk about a baby, or like a non-infant
تشايلد مثلا او وات ايفر تشايلد او فيرست
يعني
دايجنوز
metabolic usually metabolic
هل
usually
ده
baby
من
newborn.
السكريننج اللي بيتعمل لاي بيشنت
Yeah, I
دانون
mean, if
ولا لازم
metabolic,
ابعت سبيسيفيك
لا،
للميتابوليك؟
it is included. When they do genetic testing, Danon is included.
تمام
Yeah.
تمام.
So this is what I tell we never had Danon in Kuwait because we always look for it. I mean, not me, but I meant our geneticist. And apparently, this is the first known case of Danon in Kuwait. So it's definitely rare. I mean, everywhere is rare, but in Kuwait as well, it's definitely rare. Okay.
This question, the question in chat
Yeah.
from Dr. Saliba, Professor Dr. Saliba, the one who came to us, interventional cardiologist, came workshop recently from Lebanon.
Oh, welcome, Dr. Saliba.
He is with us now. Yes.
Oh, yeah. I mean, just recently, right? A couple of months ago, right?
Yes.
Okay.
Yeah.
Thank you for coming, Dr. Saliba. Unfortunately, I did not get to meet you back then, but I look forward to meet you again when you come back.
Thank you very much. Thank you very much for this great presentation.
Thank you.
Thank
Thank you. I'm trying to understand, would you calculate the risk in a particular patient, or would you anyway recommend regardless? No, I mean, I would calculate the risk. I mean, if there is no major risks, like everyone, the 6-7 major risks, if she doesn't meet any one of them, if she doesn't have any one of them, then and the calculators do suggest less than 6% risk, I would wait. I mean, unless the family really wants ICD implantation for peace of, for them to sleep better. I mean, I don't mind that, but I would probably wait because, transvenous is a big deal in pediatrics. Now with the subcutaneous ICD is not as big of a deal, but you obviously have to screen. You have to screen for subcutaneous ICD, and not every patient would pass the screening for subcutaneous ICD because of the, T waves abnormalities and fluctuating of the T waves. Sometimes with the subcutaneous ICD, it might double count. It might overtreat a patient because of the double counting and issues with sensing. So
okay, thank you very much.
Welcome. Any other questions, guys? So this patient,
patient is 15 years old.
Yeah, she's 15, so it's at the borderline, So she will come back. We will do our own echo, inshallah, with the MRI.
We want to do echo to do all these parameters for risk stratification.
Yeah, of course.
So just let me know when she is coming for echo.
Yeah, I mean, the adults, she did an echo elsewhere in an adult center, and they do LA volume. They don't do LA diameter. So I don't have the LA diameter with me, but the LA volume was normal. So I imagine her LA is not dilated, but the MRI was done by Dr. Bahia in Amiri. So but we will repeat the MRI with with Dr. Bahia at chest, and she has an appointment in March. At the same time, we'll do an echo as well, and then we'll sit with Dad and recommend ICD, yes or no. I think I would recommend ICD, probably. If not, this year, probably next year. So I don't think there's much point of waiting. It's not. I don't think it's very smart to wait, so long. But we'll see what definitely, if we decide not no for ICD, we'll probably do loop implant at the very least. Okay. It's an interesting case. So you guys might get to meet her one day, and then we might see another patient in the future. So this is so everyone is aware of Danon. It does exist. Okay.
Okay.
Okay, guys.
شكرا.
I don't know how long we took, but usually this is a nice short conference. Okay. Thank you very much, guys.
شكرا جزاك الله خير.
Thank you.